welcome. We'll get started in just a moment. Great. Well, thanks for being here today. You're joining the Pathways to Prevention webinar series. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health and Director of Outreach with the Injury and Violence Prevention Center. And today's session is entitled Child Sexual Abuse Prevention, Leveraging Systems to Maximize Reach and Impact Policy. This session of Pathways to Prevention will discuss child sexual abuse and unique opportunities for universal prevention. And I'll introduce our speaker in just a moment, but want to give a little context for the webinar series and some housekeeping before we jump in. So this series is a partnership between the Injury and Violence Prevention Center and the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. Both of our organizations are based at the University of Colorado and Schuetz Medical Campus in Aurora, Colorado. And as we gather, we acknowledge the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations. The Pathways to Prevention webinar series is designed to connect prevention workers with the latest science on protecting children and ensuring well-being of families. We offer these free monthly webinars for those working in public health organizations, social services, child welfare, the nonprofit sector, and other related types of organizations. I want to thank everyone who completed the feedback survey on training needs and preferences that we talked about in the last session. We got a lot of responses to that, and we heard that there is interest in continuing this series and also in some additional training opportunities. So we're going to be looking to share some of those opportunities with you all here. I want to make a note for your calendar that the Kemp International Virtual Conference, a call to action to change child welfare, will be held October 3rd through 6th. So keep an eye out for more information about how to sign up for that conference. And there is a prevention track to that conference that many of you may be interested in. We're going to take a pause with these webinars after this one for the summer, but we're going to be back in the fall with a new lineup of speakers. And just a note that we always record and archive these webinars on our website. We send out a link to the recording and the slides after the session, so you'll have access to those after today. And so before I introduce our speaker, I'd like to see who's joining us today. If you would share in the chat box your name, organization, and where you are joining us from. Susan, Kirsten. Okay, Indiana, Utah. Great. I see folks from all over the country are here. Lots of different organizations represented. Wonderful. We'll keep an eye on those as they continue to come in. If you have any technical questions, you can also put those in the chat for us. So now I'm going to introduce today's speaker. We're very grateful to have her joining us today. Jennie Noll is the founder and director of the Center for Healthy Children, which is the first national center for child maltreatment research. Her primary research focus areas are the biopsychosocial consequences of child maltreatment, including sexual abuse, physical abuse, and neglect, pathways to teen pregnancy and high-risk sexual behaviors for abused and neglected youth, the long-term adverse health outcomes for victims of child sexual abuse, midlife reversibility of neurocognitive deficits in stress-exposed populations, the propensity for abused and neglected teens to engage in high-risk internet and social media behaviors, and also policies and programs for the prevention of child maltreatment, which will be much of what she's focusing on with us today. And she holds a PhD in developmental psychology and statistical methodology from the University of Southern California. So thank you so much, Dr. Noll, for being here today, and I'll turn it over to you.
Thank you, Sarah, for that nice introduction, and to Terry, thank you for inviting me. Yeah, this is an amazing seminar series, and I'm privileged to be invited, so thank you. I'm sorry this has to be virtual, but I think this is the new world we live in, and As you can see, I haven't yet even figured out how to change my background. So I am in my basement. Pretty good bandwidth here in terms of the internet, so I shouldn't have any problems. But if we do or get disconnected or you want to talk to me further, I'm not hard to find at Penn State. I have about 40 slides and I can go through those in 40 minutes. And I think that I would love to leave some time at the end for some lively discussion and hoping that I get your questions addressed. I want to do three things today. I want to start out by talking about a sexual prevention program that we've developed here at Penn State and sort of walk you through what that newish and newly published prevention program looks like. Then I want to talk about a very unique state university partnership focused on universal sexual abuse prevention here in Pennsylvania and how that worked. And then how do we think about, in my center, impacting policy and practice through the dissemination and translation of research and partnerships with policymakers and lead practitioners. So I want to get through all of those things with the thread of childhood sexual abuse. So let's just start out by being very specific about what we mean by childhood sexual abuse. And I'm using a definition that's more of a universal definition published by Matthews. That is sexual acts with a child under the age of 18 that involve direct physical contact or non-contact act, where there is no or limited capacity to provide consent. So this is what we're talking about. We're not talking about peer on peer. We're not talking about adult assault. We're talking about childhood sexual abuse specifically. And then there's all kinds of different opinions about what the prevalence is of childhood sexual abuse, but I use a pooled international aggregate rate that was published in 2013 of an estimate about 15% of girls and 8% of boys have experienced childhood sexual abuse across several international aggregate data sets. In the US, the most recent count for yearly prevalence or yearly incidence is about 6,300 kids being victims of sexual abuse. Now this has plateaued over the last 15 years. If you look at the incidence reports over the last decade and a half, you'll see a really marked plateau. And the last report, in the child maltreatment report, there was even an uptick, the first uptick in nearly 3 decades. So I think that this is a lesson to us that whatever we're doing for primary prevention isn't really having the impact maybe that we really want it to. And in addition, we don't really have our hands around what the internet is doing for sexual exploitation of our kids and how the internet has opened up new avenues for exploitation and for exploitive individuals to actually have access to our kids. So we don't really understand how, luring kids into pornography, exchanging of sexual images, even luring kids offline and the lines to sex trafficking. We don't really understand how those things are operating because this is the first generation to really have that unfettered access. But this is something that's been on the rise since the proliferation of the internet, and it's a rising concern of the US Department of State. I like to talk about societal costs. I think talking about costs is a good way to impact policy change. The paper that I lean on most is the paper by Elizabeth Letourneau and her team, where they estimated the associated costs of treatment, 1 year of incidents of victims, estimated to be about $9.3 billion in 2018 dollars. And this methodology hinged on mental health costs, child welfare costs, law enforcement costs, and loss of productivity. And in my estimation, although I love this paper and I think it was expertly done, and Elizabeth and her team are the team to go to. What I've been really doing in my career is studying what does the research say about the long-term consequences of sexual abuse. And just last year, I wrote a review paper, if you want to look it up, in the annual review of clinical psychology, where I really culminated the extant research on Can we really say through good methods and good controls whether sexual abuse has a unique impact on a lot of these outcomes shown here? And so this is why I think that those cost estimates that Elizabeth and her team did are probably an underestimate of the true societal costs. And you can see just listed, these bullet points are some of the highlights of what I was able to talk about in this paper, but are emerging results of some long-term longitudinal studies that have followed observationally survivors through multiple decades. And we're even seeing things like, early cognitive deficits and accelerated cognitive aging in these populations that, when we control for everything else, are seen to be uniquely associated with the very early life stress and trauma of sexual abuse. So what do we know about how sexual abuse happens and when it happens and where it happens? And some good research shows us that about 90% of victims actually know their perpetrator. About 30% of victims are abused by a family member, so someone in the household who lives there, or someone who is a family member who has access to the kids regularly. And 60% are abused by someone who's trusted by the family. So, these are people who the parents actually trust to have their kids around. Right? They have direct access to these kids. We know that about less than 45% of victims disclose within the first 5 years. So this is a delayed disclosure, sleeper effect kind of phenomenon that we're dealing with. And about studies between 12 and 17%, showing 12 to 70% of victims never tell anyone prior to adulthood. And then sadly, I think that we need to pay really good attention to is that about less than 20% get referred to evidence-based trauma treatments. So we have a large number of victims not coming forward, and we have a large number of victims not getting help. So when you think about some of the aspects on the last slide, and you think about what makes sexual abuse hard to prevent, we can put together a pretty good list for those of us who actually hear these stories over and over, either in our research or in our practice, and what the stories can tell us about why sexual abuse either happened or went on for years and years. Sexual abuse is hard to talk about. See, sex is hard to talk about, much less sexual abuse is hard to talk about. And many people don't believe that this kind of abuse or this kind of trauma or this kind of horror can happen in their families or in their community or in their schools. Physical signs are rare. And unlike physical abuse and neglect, you don't see bruises, you don't see evidence of neglect like you do in neglect and physical abuse. And these signs can be really hard to detect. Physical or sexual abuse very often occurs in a shroud of secrecy. Those of you who worked with survivors or understand how perpetration works, there's often a very secretive relationship that happens. There's a lot of effort that goes into keeping it secret, including threatening the child that if they tell, something even worse will happen to them or someone that they love. So it's very hard to prevent something that's so secret. Sexual abuse is also difficult to prosecute, and evidence can be very difficult to obtain. It's hard to get survivors to come forward if they are faced with this difficult prosecutorial process. And also there are laws and policies that put limits on disclosure timeframes. Statutes of limitations are alive and well in this country, putting limits on when victims can come forward. So it's often hard to encourage a victim to come forward with a disclosure after many years have gone by. And sexual abuse disclosure can result in significant family disruption. And often the child can feel responsible for that disruption once they come forward. It's sometimes difficult, and the stories that I've heard over and over are the reasons why children didn't come forward sooner is this disruption, and the family is going to be broken up. And then again, we just don't understand the real scope of internet sex crimes and how to even talk about prevention of in social media and other internet behaviors, because we don't even understand how those are operating systematically in our country. But when we think about prevention, we think about the damage that sexual abuse can have on development and the difficulty with which disclosure happens. We're motivated even more strongly for primary prevention, and that is stopping the thing before it happens. That's what we mean by primary prevention, stopping sexual abuse before it even occurs. And the most impactful way to think about primary prevention is a universal strategy that would impact the entire population. And so when I think about primary prevention of sexual abuse, and I think about a universal strategy, I think about leveraging large systems out there that will help us reach the maximum portion of the population to get a primary prevention program. And so in this sense, we talk about reach and how reach matters when we're thinking about primary prevention. Reach matters because reach is a major driver of the universal impact of a program. It communicates. The more people you reach, the more successful your strategy. And the more people you reach, the greater your reach, the greater the probability that rates will actually be impacted. And isn't that what we're after? Is that rates of childhood sexual abuse would decline significantly. Reach is also a major driver in cost analysis. So the more people you reach, the more cost effective the implementation. So you want to reach as many people as possible because the cost of individual implementation then is driven down, down, down the larger you reach. And cost matters. And we're going to talk about cost when we talk about policy, but reach is a way to think about controlling costs. And then reach is not only about reaching people, but reaching numbers of people, it's about maximizing participant engagement. So once we have people, we've identified people we want to reach, then engaging them in the process, we want them to complete the entire program. We want them to get out of the program what we designed, right? So we want that participant engagement to be talked about. Now, when I done a lot of thinking about primary prevention of sexual abuse, and I just wanted to outline for you what the extant prevailing strategies are in this arena. And some of you are going to be very familiar with these strategies. I'm not going to say a lot about them, but the basic conceptualization are in many different buckets. The first big bucket is the larger community. So a universal strategy around creating awareness within the larger community. And the National Darkness to Light Stewards of Children program is just this. It's something that is delivered and is designed to be awareness promoting in the larger community. Organizations think about this, how to prevent sexual abuse within organizations. Circles of Safety is one of these programs whereby organizations can adopt some strategies to protect kids, especially those that are largely child-serving organizations. There are some promising programs that are emerging out there that are focused specifically on those who might be perpetrators or potential perpetrators. There's a really intriguing program in Germany called the Dunkelfeld, which are public service campaigns to people who might be attracted to young kids and opening avenues of treatment for those who come forward to say, I have an unhealthy attraction to kids. And Stop It Now is starting to adopt some of these principles. I'm really intrigued by something that's happening at the Hopkins Moore Center, again, by Elizabeth Letourneau's group, teaching responsible sexual behaviors or responsible behaviors to middle schoolers, to teach them that it's not okay to sexually exploit or to sexually have harmful sexual behaviors toward younger kids. So these are sort of like potential perpetrators, potential like stopping abuse before it might happen within the perpetrator population or potential perpetrator population. The other strategies are sort of hardening the target kind of strategies, usually delivered to children and adolescents through the school. a good example is a program called Safe Touches. It's an evidence-based program that's delivered to K through 3 children, and it's delivered via puppet show, and it teaches basic strategies and education about what sexual abuse is, and that it's not your fault as a child. And the adolescent program that I talked about, Elizabeth Letourneau's program, really hardens the target for adolescents too, who are learning about healthy sexual behaviors and might discover that they're being exploited or being abused. What's left out of this puzzle, from my perspective anyway, as a developmental psychologist, is parents. Some programs specifically designed to target parents. As many of you know or will remember, I come from Penn State. I came to Penn State after the Sandusky scandal. And one of the things that I heard over and over and over from the community and from parents and from when I studied the transcripts of survivors from the Sandusky abuse was that their parents didn't know what was going on. They didn't recognize it. Many parents in those depositions said, if I would have known, I would have stopped. I would have done this. We heard it all over the community. We didn't know, we didn't know, we didn't know. So I started thinking about parents and why would we even want to think about parents as a good avenue, good way to think about sexual abuse prevention. And, you know, we know that parents have the greatest control over children's environments. Parents can set those limits. They are the gatekeepers to who gets into the environment of kids. They're the chief observers of child behaviors and emotions. So if a child is withdrawn or having some externalizing or internalizing reaction to being with an adult, parents are going to be the first to notice that. They also control access. They know who gets into the home and who takes care of their kids, and they are responsible for child supervision. So they're the chief gatekeepers. So I wanted to really capitalize on the contact that parents had with kids and thinking about primary prevention. And then also to think whether there are certain parents or households that are at particular risk and how we might think about sort of more targeting when we think about primary prevention. One of the things that we've understood from Ken Dodge's work over the last decades, and in this really informative paper that was written recently in 2020, is how targeted prevention really is a cost-effective strategy when thinking about universal primary prevention, because when you hone in on the highest risk groups, you actually increase the reach to the people who need it most. And he's actually showed that that's the most cost-effective strategy that we have available to us. So that leads us to think about these households that might be at the highest risk. And then how would we maybe target those households? And I want to stress here that when I talk about households at highest risk, I'm not talking about households where there are parents who might be abusing their kids necessarily. I'm not talking about that. I'm talking about households where parents may inadvertently create environments where exploitive individuals gain access to their kids, all right? So that's an important distinction. I'm not talking about at-risk individuals. I'm talking about at-risk households where parents in those households could benefit from some skills-based training on how to protect kids. These high-risk households, what we know about where sexual abuse occurs, can be in households where there's already mental health or substance use problems on the parent side, households with low social supports for caregiving of children, where surveillance and supervision might be low. And what we know, one of our most potent predictors of sexual abuse is a prior involvement with the Child Protective Service system. So when I think about this, and I think about leveraging large systems that we could work with to maximize the reach of our targeted population and our high-risk households, it is the Child Protective Service system. So I'm thinking about how do we leverage that system to help us maximize this reach. And in doing so, I really wanted to, instead of developing a whole new program, because I don't want to develop a whole new program. No, that takes decades, and we know what that's like. And not a lot of people want to adopt an entirely new program, right? Getting a new program into the evidence base is a little bit difficult. So what I wanted to do was build on the foundational skills that are taught in already funded parent education programs that are currently delivered to at-risk households through the child welfare system. And then to add sexual abuse prevention programming to these already existing parent education programs. And in doing so, maximize the efficiency, the cost effectiveness, the sustainability, and the scalability For example, a lot of you are familiar with a lot of these programs that are already used by the child welfare system, particularly for families who are at risk for lots of other things. And programs like Incredible Years, Safe Care, Parents as Teachers, they do a good job when you look at the evidence base of preventing physical abuse and neglect, but there's no good evidence that these programs that are already adopted by the child welfare system largely impact sexual abuse per se. And it's not surprising because my team and I really dissected the curriculum of most of these evidence-based programs, and they don't include information about sexual abuse prevention or sexual abuse prevention programming. So what we wanted to do, and I've done most of this work with my excellent colleague, Kate Guastafaro, who can't be here today at Penn State, we developed a program we called Smarter Parents, Safer Kids, and it's designed to be added in a single session or 60 minutes braided throughout. It's designed to be added to these evidence-based parent education programs. And the curricula that we developed covers kids aged 0 to 17. We'll talk about that in a minute. We have both provider and parent handbooks because this is a very skills-based behavioral strategy education curriculum. And so parents go home with a lot of homework and things that they can do on their own throughout the implementation of the parenting program itself. The goal is to change behaviors, not just attitudes, not just education and knowledge base, but specific skills and specific programming that helps parents understand what behaviors they have and now have skills to implement that will change how they think about sexual abuse and react to risk for sexual abuse. It culminates in a family safety plan. That is a real strategy that parents then can implement in their own home and in their own communities. So how does this work? So we leverage the foundational skills that are already taught in these funded parent education programs. So for example, current education programs, parent education programs, they already teach healthy development. They're already talking about what healthy development is. So let's add to that, what is healthy sexual development, right? They're already teaching how to improve parent-child communication and how to approach kids and how to create safe, communication avenues between parents and kids. Let's do that same thing for communicating about sexual abuse and sexual topics. Most of these parents also address safety, child safety. In that context, let's have parents address creating a safe environment in terms of sexual abuse, safety from exploitive individuals and sexual abuse. So this is what we're doing. We don't have to have a brand new program that teaches all these things and that takes 12 weeks or whatever, because those skills are being taught, those foundational skills. We're adding to it, then translating that into concepts of sexual abuse prevention. So specifically, how our curriculum does that is in the realm of healthy sexual development, we teach parents how to recognize healthy sexual development milestones, how to answer questions about sexual development in a developmentally appropriate manner to their kids who are growing through development. using anatomically correct names of body parts, identifying inappropriate sexual behaviors and what to do if they recognize these behaviors, because oftentimes sexual development can signal exposure to inappropriate sexual behavior. So this kind of time development can help parents understand, well, why does my kid know that? Or why are they acting older than they are sexually? What might be a conversation I could have with them about that? It helps parents to help kids identify healthy versus unhealthy sexual behavior. So if something is happening to them, they know that it's unhealthy and they can tell their parents. And then using correct anatomical names aids in really identifying inappropriate touching. There are examples that we have from our work about one little girl who told her teacher that her stepbrother always wanted to touch her cookie. Well, the teacher didn't understand what that was and thought, well, you should share your treats with your stepbrother. That's okay to do. But she was talking about, that's the name that they use for vagina in her family. So that was an ineffective strategy of a kid who really was trying to tell their teacher that something icky was going on, right? In the realm of communication, what our curriculum does is it teaches parents how to initiate, even where to have, and how to promote open communication with children, and importantly, other adults in the community about sexual topics, sexual development, sexual safety, and sexual abuse. So even things like, when you're with your kids in the car and you don't have anything to talk about, you can talk about a story that you heard in the news about something that happened to another kid, and open up dialogue about, has that ever happened to you? Or what would you do if, opening up this dialogue, open up dialogue with other adults about, this doesn't happen in my family. Here are the sexual boundaries in my family, right? Our kids, have very separate, zones where they can be naked and where we can be naked, and those kinds of personal boundary conversations. And then importantly, teaching a parent the difference between a surprise and a secret. Like if someone is around their kids who are continually wanting them to keep secrets, keep this a secret from mom, this is a secret, this is a secret. That's different from a surprise. A surprise that you want to share with your family is different from a secret that you have to keep from your family. Helping parents understand how to have those conversations with their kids can empower parents to protect kids, because they have those communication skills. It can break down barriers to addressing and confronting inappropriate behaviors. And it helps parents set appropriate sexual boundaries in their household. And then when we talk about creating a safe environment, the curriculum really gets into monitoring the child's activities inside and outside the home, so they know where their children are, they know what kind of environments they're in, they know where they are online, right? They know who they're gaming with, they know who's asked them to be engaged in social media, they know what their privacy settings are, those kinds of things. How to vet people that their kids spend time with, even vetting babysitters. There are ways to do that. Right? And understanding the histories of the people that they're sending their kids home with, or that are watching their kids, and establishing, screen time and internet safety rules, like I said, and then really culminating in the development of a home safety plan that identifies vulnerable places or vulnerable people or activities or behaviors that can be monitored, so that the parent can keep abreast of who their kids are with and what kinds of activities might engender a kid saying, I don't want to go with that adult, or I don't feel comfortable with that adult. Or how do we talk about grandma about they don't like how she kisses them on the lips? How do you have that conversation? How do you identify those signs? If they are indicative of abuse, how do you react to them? And then how do you get help? This gives parents tools to create that environment. It helps them to identify dangerous and exploitive online and offline behaviors, and it educates parents on when to get help and how to report. And not just for kids in their own family, but for their neighborhoods, their immediate community. This might be something that grandparents can help understand in terms of their larger community, whoever the caregivers are. But this is a real community strategy, help parents identify places in not just their home, but in their community where these things are happening. Just really quickly, I only have about 10 minutes left, so I'm going to go kind of quickly on this, but we published our first RCT showing that we indeed were able to change parents' behavioral strategies and behavioral commitment up to 1 year post implementation. And we did this when we added this to the Parents as Teachers program, which was one of the most largely proliferated parent education programs in the country. So we're able to show not just the RCT worked in the randomized controlled trial, but we published papers on feasibility and acceptability to parents and providers. We are now replicating this in a really large R01 that just got a first percentile, so a really good score. We expect it to be funded, where we're really partnering with Parents as Teachers National to move this to their national implementation model. So they're really excited about this with Parents as Teachers. What we want to do is explore how to add this to other parent training programs. We developed it so it could be additive, but I think more research needs to happen, especially in terms of more group-based programming like Incredible Years. Is it going to work the same there? Does it have to be individually delivered? We still don't know that. We are also working with the state of Pennsylvania to develop this as a standalone a program for parents where it's not parents who are in parent training, but parents in general. We want this to be implemented alongside our school-based programming. So we're working with the state of Pennsylvania on that. And of course, as we all are, as all you are, identifying sustainability and how do we fund this and how to leverage other systems to do this. I wanted to quickly showcase for you a large state-initiated partnership with state of Pennsylvania and Penn State to test what we call the Safe and Healthy Communities Initiative, which is a coordinated effort using 3 big strategies for 3 big sections of what I call the prevention pie. And that is parents, where we're taking smarter parents, safer kids, and adding that to 100% of the parent education that goes to families who are referred to General Protective Services in Pennsylvania. We're implementing a community-based strategy. So the evidence-based stewards of children, we're trying to reach 5% of the adult population, or about 72,000 adults. And then we're implementing the Safe Touches program, which is an evidence-based hardening the target program implemented in our target was 100% of second graders in these counties. I'll tell you about that in a second, but the goal was to reach about 15,000 kids. And so we implemented this coordinated strategy in 5 counties, experimental counties, and we have control counties who are not getting this as our comparison. And so we've been implementing this since almost 2019 in kind of a step design that would help us do a interrupted time series design. Which of these would be most effective in changing rates. So we started with the community campaign and then the school-based intervention, and then we've been implementing the parent-based intervention. We have evaluation. We are doing the evaluation part of this, and the state is actually doing the implementation part of this. But we look at referrals and substantiation and conviction rates using statewide databases for this. We're assessing knowledge, attitudes, and behaviors pre, post, and then 6 months and 12 months for all the participants in all of these programs. And in addition, we're doing more population-based awareness assessments. So we did random visit dialing that is now changed to random online surveying across the state, and looking specifically at our experimental counties to see what kind of change we're getting at that level, with the expectation that referrals are probably going to go up. This is one thing that you have to convince policymakers when you're doing prevention, is the problem's probably going to look like it's getting worse before it gets better, because when you educate the population about what happens, you're going to get more calls. And when you get more calls, you're probably going to get more substantiations. But the goal is that once we get everybody educated and everybody's on the same page about what sexual abuse is, there'll be less nuisance calls and more informed calls to protective services, such that by the end, we would have more convergence between referrals and substantiations, with the ultimate expectations that altogether substantiations would go down. So this is our basic design. So how are we doing with this? Well, we're not finished completely, but we are with the school-based program. And I'm happy to report that in our experiment counties, 97% of school districts signed on for this. That was more than we expected. And we could talk a lot about how we accomplished that, but I'm happy to do so. We exceeded our goal. So we reached over 16,000 kids, right? I was very, very happy with this. They received the workshop. And our evidence shows that when we went back into third grade to assess these kids again to see what they remembered, they were able to remember the curriculum significantly. So this is sort of the first time it's ever been shown that kids can actually get the information and then they can retain it for at least 1 year. Providers, facilitated, the providers who went into the classroom to do this facilitated many disclosures of kids right there in the classroom or immediately after. So there were a lot of, and I don't remember the exact numbers, but when I think about this, it's over 100 kids who actually, were able to come forward directly as a result of the program. And then we heard through our CACs and other providers that the program was referenced even in forensic interviews and even to one judge where the child said, the puppets taught me that this was wrong, right? So we're moving ahead with a larger strategy to get this program implemented on a much more wide scale in Pennsylvania. How did we do with the stewards of children? Well, not great, guys. We only reached 20% of our goal so far. We've extended this for another year because we want to reach more, but this is hard. It's difficult to get adults to volunteer to do this. We've done everything that we can think of to improve the implementation, going to corporations, writing letters from Penn State, offering incentive, offering days off, offering, all kinds of things. And we still cannot get people to volunteer in the large enough numbers to do this. There's a large public awareness campaign associated with this. So we'll see what impact that might have had on the community awareness. We've just had a hard time with this. And those of you who have done similar strategies can speak to this, and perhaps we can learn from each other on how to do this better. But a larger engagement plan is certainly needed for this. And we racked our brains for 3 years to try to improve this. How did we do with our Smarter Parents, Safer Kids? Well, what we learned is that it's difficult to get child welfare agencies to adopt the evidence-based programming. So they had to have some evidence-based parent education program to add this to. Our state partners would not add this to anything that wasn't evidence-based. So that was hard to get all of our partners to do that. Some agencies just didn't want to work together. Some agencies didn't believe that you should, even parents, talk to their kids about sex. We had a hard time with retention, even in the parent education programs themselves. So if parents didn't complete the parent education program, they didn't get our section. So more improvement, more work on reach this way needs to happen. We were successful in certain pockets, but this needs a lot more work. The next steps are to then implement and start to think about policies that will help us with our reach. So we're working with the Pennsylvania Department of Education and the Pennsylvania Child Welfare System to think about policies that would help us fund these things. So for example, in the child welfare system in Pennsylvania, they are considering adding Smarter Parents to their list of family first evidence-based programming, so that this program can be reimbursed through needs-based budgets if it's added to an evidence-based parent program. So we're already having those good conversations, and that could be a really great way to increase that reach, is to incentivize child welfare agencies to include this in order to get those special needs grants and so forth that most states have. And getting our Pennsylvania Department of Education to add safe touches to their prevention programming that's covered by Act 48. We've done a cost analysis to show how much this costs, right? That helps with convincing policymakers that this could be a viable aspect of prevention programming in schools. And then we're talking to our state mandated reporter training agencies about including sexual abuse prevention more deliberately in mandated reporter training, because our mandated reporter in Pennsylvania is really focused on sort of the forensics around child abuse. And there's not really a lot of information about what sexual abuse is and what prevention could be. So if we could integrate some of the strategies of stewards of children in the mandated reporter training, which everybody has to take, might our reach, grow, and might the reach of sexual abuse prevention be realized at the 5% of the adult population like we want. I'm going to go through some of this quickly. I don't really want to get into the weeds on policy because I want to talk much more about your questions, but I just basically want to tell you that how do we think about impacting policymakers in my center? We use what we call the research to policy collaboration model. I'm sorry. The research to policy collaboration model, which is an evidence-based model used in prevention science broadly that helps researchers understand how they can translate and use their science to impact policymakers. And we do this through 4 basic tenets. And that is, first, we ask the right questions, ask pressing questions in our research, conduct the best research we can. We translate our research into messages that can really resonate with practitioners and policymakers, and then try to become a resource for these people so that we can work together on the right research that needs to be done, and they can come to us when there are policy levers that need to be pulled so we can help. So we do this through community-based participatory research, which some of you know is an evidence-based way of thinking about engaging your community in your research. So we work with our community partners, usually our child welfare agencies. They tell us what the issues are, right? We try to identify manageable research projects that we can do at the behest of our agencies that really matter to them, that matter to certain identifiable policy or practice issues that research could speak to. If we were able to change a certain practice, this would save money, this would save lives, right? This would save caseworker retention, et cetera, et cetera. So we're in the weeds asking these questions with our community partners, okay? We conduct the best research. My people have to do the best methods. If we don't use the best methods, we will be assailed at the policy level, right? So conducting the best research, getting it in high impact journals, and then implementing models of sustainability when you leave that community. Then, of course, the translation matters. We talk about this a lot. Work with your community partners to translate messages into really targeted policy initiatives, right? Get buy-in from your community partners about how to translate that science, right, into messages that are really going to work in terms of policy and practice change, right? Let that science speak, right? Do these things like when we do this, we can save money, right? The cost benefit analysis of certain policy changes. That's all the kind of research that we do with our community partners. And then ultimately we become a resource for policymakers and large practitioner organizations so they can come to us and say, hey, there's this policy coming down the pike. We need some help research-wise. What's the best research out there? We have a rapid response coalition of 500 members across the country. When we get an ask like that, we do this blast and we get researchers from all over the country adding their ideas and their input in papers. Like, here's the best research. We culminate that, we translate that. That becomes things like policy briefs and fact sheets that can then be disseminated. And then ultimately become a resource so that you're invited to do the briefing. You're invited to do the hearing. So my center has been involved at the state and federal levels on major child welfare policy initiatives, including Family First, CAPTA, and so forth, where we were even invited to give congressional testimony on the Child Abuse Prevention and Treatment Act based on what research shows about prevention and how it works. So I'm going to stop there so we have some time to talk. I went a little bit over, I'm sorry, but I think I can hang on if people want more. And should I stop sharing my screen?
Sure,
Sarah?
that's fine. Thank you so much, Dr. Noll. That was fantastic. Just packed full of really excellent, really practical information. And it's great to hear about what you're working on in Pennsylvania. We're getting lots of questions coming in. So kind of a mix of more practical ones and sort of bigger picture ones. So, and I would ask people, if you have additional questions, look for the Q&A box, which should be in your Zoom controls where you can add your questions. Let's see. So some sort of implementation questions. Melissa wants to know, when will parents as teachers be rolling out the new part of the program?
Well, wouldn't it be nice if it was tomorrow? I think we need to do some more research, so that they're allowing us to do a randomized controlled trial. So I can't tell you, when you might see it in your community, but it's a national thing. So some of their partners are going to be implementing it right away. But we're doing a stepped wedge design, which means it's not fully randomized where agencies get it and some agencies never. We're doing a gradual rollout. So there's many of these agencies that will get it once they're trained, or once we get certain agencies on the books implementing this. So it's a really cool design whereby we don't have just an arm of, you don't get it, an arm get it, but a stepped wedge rollout design. So we just got the scores this week for the big NIH grant. Council meets in September. We're hoping first percentile is good enough. I'm hoping that's good enough. And then it should be starting pretty soon after that. But certainly reach out to your local parents, teachers, provider and see if they want to sign up.
Wonderful. Thanks. Another question from Rachel is, do you recommend any evidence-based programs for junior high school students?
Yeah, that look up that more center, the more center it's a Johns Hopkins School of Public Health. It's the Responsible Behaviors for Youth program, and it's a program for middle schoolers. That is also garnering the evidence base right now. They've had one RCT funded and they're starting to publish, but reach out to Hopkins.
Wonderful.
To Elizabeth Letourneau in particular.
In particular. Great. Okay. I want to say I was so impressed at 97% of school districts participating. That is really amazing. And I wonder what you think, if there was anything particular about how that was offered to school districts that you can point to in terms of that success. And then also bring in another question. Someone asked about sort of political context and how to combat opposition to talking about healthy sexual development in more conservative areas that may not be as supportive of that.
Right. So yeah, I think this is a two questions in one, but same answer maybe. So the reason I think we were so successful is that we were doing this as a state partnership. So we didn't have to say, this is Penn State coming to you. We could say, this is the Commonwealth and they are doing this initiative. And we want to do this. And here's the evidence base on why this works. Because Safe Touches had been done in New York, right? We weren't the first place to do this. And they had showed some pretty good outcomes. And then what we did was we put together webinars and self-paced webinars for school district superintendents. We had to come at it from the superintendent level, because if the superintendent said yes, then it was much easier to get buy-in from the schools. To have it be one session, one classroom session was huge, guys. It's really hard to get buy-in from schools if you're saying we got to come in for a whole semester or whatever, like a lot of programs do, right? To do the cost benefit analysis to show that it didn't cost much, and to have providers in the community providers do this. We're not teaching teachers, right? Providers come in and they take one classroom time, right? So all of those kinds of things, and then to really talk about the evidence about talking to kids, to look at some of these large implementation studies of school-based programming we were just publishing our implementation paper on safe touches. We did not have one adverse event, not one adverse event, not one parent came to us screaming and said, you can't do this. You know, they could opt out. They could keep their parents out. We offered that. So if they really didn't want their kid to have this, then they would not show up that day, or they were funneled off into a different classroom, whatever. So there are ways to get parents to buy in that way. But I think being sensitive, educating people about what the science really does say is the most important way to break down those barriers.
Well, thank you for that answer. A couple of sort of related questions are coming in about whether there's a link between previously being a victim of sexual abuse and being an offender, and also about access to treatment. How can perpetrators get treatment, and what does that look like?
Right. Okay. So look at my 2020 review paper on this transmission of being a victim to becoming a perpetrator. The evidence is really, really, really slim on that, if any. But look and see. I review all that. And if you can't find that paper, just email me. I'll send it to you. It's not a problem, or you guys could post it or whatever. The evidence is pretty small. However, that doesn't mean that those who were victims don't have trouble talking about it, or creating safe environments, or understanding boundaries and limits. Those are all very viable and very evidence-based pathways to how do we think about protecting our own kids, right? Not about me abusing my kid if I've been abused, but the ability of me to protect my kids from, or recreate an environment in which it happened to me. That's different, okay? And then you wanted to know about treatments for perpetrators. The US doesn't have great systems for that. Stop It Now is trying to implement some of these things whereby if you have certain feelings, you can go to certain websites and you can get hooked to people who have expertise in treating attraction to children and so forth. Other countries are doing this much better than us. The UK is implementing some really effective strategies through the Lucy Faithfull Foundation and the NSPCC Scotland. But other countries are miles ahead of us in this. But I will just stop there because that's as much as I know. Elizabeth Letourneau knows a lot more about this, by the way. She should come to your series.
She's on our list. Wonderful. Another question, someone wants to know, is there a way to pilot the Smarter Parents, Safer Kids curriculum? And are the materials available at this point?
Send me an email. We're going to roll out, we're going to try to do our standalone trial pilot. And if you want to be part of that, let us know, because we'd like to be able to develop this for parents. In fact, the state, part of our sustainability plan in our state partnership is they're willing now to offer safe touches to multiple counties. It's going to be now in 12 counties after this trial, and they're going to pay for it, but only if you also adopt strategies to reach the parents whose kids are getting safe touches in the second grade through their PTAs and other avenues, so that parents will get the standalone Smarter Parents, Safer Kids that we can marry with the curriculum that's going on in the second grade classroom, so that kids come home saying, I got this thing in school, and parents can say, I went to this thing and let's talk. So that's a strategy that we're starting right now in Pennsylvania that will be starting implementation like next spring, I think. But if you're not in Pennsylvania and you'd like to do something in your own state, let me know, and maybe we can think about ways to do this there too.
Great, thanks. And I just shared your email in the chat for folks who may want to reach out, and we'll also include it in the follow-up message from today. And we only have one more minute. I guess the last question I would like your thoughts on is pediatricians and healthcare providers as routes for prevention. And I ask because my child's pediatrician, every time they do a physical exam, they do a little sexual abuse prevention spiel for the kids, and also I'm sure for the parents. And I'm curious, how much is this on pediatricians' radar and what work is happening?
Right. I would look up Howard Dubowitz's work for that. And if you would be willing to send me some information on what that curriculum is, I would be love to understand it, because we are trying to engage pediatricians in this conversation. It's hard because they got to do everything, right? They got to do everything, and to take 5 minutes, and then what if they find out, and what are the supports there for mandated reporting, et cetera, et cetera, et cetera. But there are some Howard Dubowitz and his SEEK program, it gets at it a little bit differently because he's assessing risk for maltreatment in general in that SEEK program. But we're starting to think about ways to implore the American Academy of Pediatrics to take this on more readily. We need more research. We need more cost analysis. We need more, does it really work? So I would love to talk to you more, Sarah, about what that actually looked like and where it came from, because yes, I didn't leave them in my pie, my prevention pie, because it's really only working for physical abuse and neglect right now with the SEEK program, but that is another piece for sure.
Yeah, great. Well, we can connect about that for sure. I just want to thank you so much for bringing so much expertise and knowledge here today. And to everyone listening, thanks for your great questions. I'm sorry we didn't get to all of them, but feel free to reach out to Dr. Noll if you have follow-up questions. And thanks again. Hope everyone has a great rest of your day.
All right, thank you. So